Welcome back, everyone. Just a few little announcements before I start the video. I'll keep this really quick. If you need help with CPAP, you can schedule an appointment with me. I also send level 2 sleep studies anywhere in the US to your door, if that's something you're interested in. And I have just a few more spots for the service I was mentioning in my last video of sending a sleep study that's level 2 and high quality, but for a longer period of time. If you're interested in that, just send me an email. And I also want to mention that the sleep tracker that I did in the last video, it still has $50 US off. So if you're still interested in buying it, that discount code still works. And again, as mentioned in the last video, I now have a Patreon. So for those of you who are eager to consume the content, I have my Mind interview with Dr. Koppelson uploaded onto my Patreon, where we go over my scans and my maxillary expansion results. All right, guys, I hope you guys enjoy the video.
Nice. And it's just lovely down there.
I like it. Yeah, I try to chill with the people whenever I have an opportunity. So
Nice.
come on down.
Yeah, totally. It's the Northwest as you would expect it up here today. It's cloudy and just kind of like comforting weather type of thing. So
I miss that sometimes. It justifies the indoor lifestyle, which I quite like during.
yeah, exactly. It's a lot easier. Let's see, how's the podcast doing? Is it changing much? Pretty much.
Yeah, people. So I just released. So you're featured in about 2 videos now. I uploaded the one where we went over the plans, and then I just uploaded yesterday for my first 2 weeks post surgery, and it's doing really well. People are pretty interested, and yeah.
Got it.
I'm not sure if you saw more people call the office or whatever, but people seem to be having positive discussions about
It's good.
our
I mean, it's good
conversation.
it's a good service for people, and I mean, not necessarily come here, but just come anywhere. It's a good thing to help out with breathing. So, I mean, I'm happy you're doing that sort of thing, advocating for it, because I mean, for the right people, it makes a ton of sense. It's not perfect by any means, but um, it sure is helpful though. Kind of seeing you through it and hearing like a real life experience is always great. So, this is good.
Yeah,
Um,
totally. I
so
agree.
let me see. I have the dolphin images. I can pull up the 3D imaging. How are you feeling, by the way?
Good. That was actually one of my questions. Overall,
Face
like
is,
drastic.
face is going okay.
I think so. Yeah, I think there's a little bit of swelling here still, so I don't feel like I got my full smile. But
Yeah.
I think I look pretty healthy.
You are week 8? No,
Week
you had
7-ish.
surgery. Let me see on the calendar.
I have this
Uh,
October 2nd, so let's say 4 weeks
1,
plus
2, 3, 4,
3
5,
more
6,
weeks.
7. 8 is Thanksgiving. So yeah, right there.
Yeah.
All right, so you're 8 weeks. Yeah, I mean, there's still a little bit of swelling and kind of mobility stuff that keeps getting better. Um, so uh, now that a little bit of swelling and like lip mobility issues still sticks around, that gets better. Are you still on track for marriage? Did your fiance?
Yeah, she accepted the new me. We're in.
Okay, well, that's good. That always worries me.
To be honest,
Uh,
I like it. I can't. I don't know. She says she doesn't care, which I think is kind of true. I think she just says I look a little bit different, but not bad.
all right, yeah, and you, that's good. Because yeah, by now have you started chewing and everything, and that feels okay?
Yeah, I just started chewing. It's been going really fast. The first couple of days, I was kind of sketched out about it,
Yeah,
and the pressure felt weird. But now I'm kind of getting in the
nice.
roll. Yeah.
Yeah, are you doing something for the holiday?
Just going on a honeymoon and that's it.
Oh, when is your
Or
wedding,
what
by
do you
the way?
mean the holiday? Thanksgiving?
Thanksgiving holiday, yeah.
Oh no, I don't have any plans scheduled into
Oh,
the.
got it.
Yeah.
Okay. Because you may not really be doing that sort of thing. But yeah, I mean, usually around here, like getting into soft food, like turkey and, you know, pies and stuff should be fun.
Yeah.
So yeah, that's good. I'm glad you're doing well with that. How's sensation?
Good. That hasn't been an issue at all for me. I thought you killed it like day one. I could
Oh,
have
good.
lived like that forever. I can't even tell. Maybe here's a little bit numb, like right here. Maybe here, but I never think about that. It's
Nice. Yeah, that's great. And your sleep was good, and then it was kind of up and down a little bit.
yes.
How's that doing?
So first 3 weeks, I was like convinced, just cured for sure, no more problems, right? I even left my CPAP machine in Canada when I went to Mexico City because I was like, there's no point in bringing this. I got
Yeah.
to Mexico City, which is 8,000 feet plus altitude, air quality
Oh
is
yeah.
pretty terrible, and it's hotter, and it was just a horror show for probably a week. And then I got the flu, but
Yikes.
now, yeah, it was pretty bad.
That's terrible.
And then I started looking at my sleep tracker data. I'm not sure.
Yeah.
And it was looking pretty, it was kind of just going all over the place. Like some nights, and it's very well correlated with the AHI. Some nights it was like 3, and then there'd be other nights it was 20,
Oh,
which is, I think is positional. I think my airways open better in certain positions. Plus there's the flu. And plus I noticed this isn't going to come as a surprise to you, but just my nasal breathing is somewhat compromised. It gets a lot worse, a lot pretty fast. Like
yeah.
keeping the nasal passages open makes a big difference.
Yeah.
I would say the last 5, 6 days, I've noticed another improvement in patency, it feels like. I've kind of neurotically constantly tested how it feels to just breathe relaxed and let the airway kind of, right, every day, like probably 100 times.
Yeah.
And I
Okay.
noticed the last couple of maybe 5 days, it seems to be more open now. Anyways, long story short, I would say drastic improvement. I do kind of sleep on a tiny incline still because it's better. It seems to get a lot worse if I go all the way flat.
Sure.
But I haven't been using the machine, and I mean, I slept 8.5 hours last night.
Oh, that's great.
I dream like I never dreamed before, which is nice. But
Yeah.
I can tell that I can tell there's still sleep disorder breathing. How bad it is, I was hoping to ask you a little bit about. Seems like no one has an answer. I spent a lot of time digging into trying to find literature that has sleep studies. Seems like the earliest ones are like 1 month with really small sample sizes and mild cases and stuff. And then after that, it's like the 3 month point. So I couldn't get an answer really. Do you have any comments about that?
On
Like,
the interval between, like, why is your sleep variable while you recover?
well, more just like, when do we expect the results to be in? When do you go to patients, okay, like, no, this is it? Or is it really different depending on who it is and the symptoms?
Uh, well, yeah, because there's a few things that you brought up. Things like nasal breathing, like reestablishing nasal breathing is kind of an important thing. And trying to get people back into their normal life. In your situation, going back to elevation, um, you know, people going to elevation can cause sleep apnea. I mean, we all experience that. There's good papers on that. And so that those sort of things, like, and also sleep position, right? Like, just I want them back into their normal life to some extent. I don't know if you lost much weight, but the general thought of like why we wait like 3 months or so is to get through that bumpy period and kind of get your weight back and be at a relatively stable spot. And it's also partly logistics, like you don't feel like getting a sleep study until then, and kind of getting it all set up and everything. So it kind of just gets settled into where we typically discuss it right around my 6 month interview. And people seem to get it like 3, 4, 5 months. Because I don't think everyone has access to the resources to get studied, maybe as you do. So, but having the capacity to study more in depth would be great. Because it's very, very typical story that I hear in terms of it going up and down. And I generally want to see if there's anything in the way that's causing it. Because, like, when to start myofunctional treatment, like tongue retraining exercises, when to do something for the nose, whether to try nasal sprays, or nose procedures, when to have a dice, those sort of things tend to be kind of if you have residual apneas.
Right.
So I guess my answer is it's largely a practical reason behind that, because of all the other stuff happening with jaw surgery, like why we test people at like 3 months, 3 to 6 months or so. Because I don't know if you'd be surprised, but there's a good chunk of people that don't get retested.
Oh, yeah. Is it
I
those
mean,
usually?
yeah, I'd like to get them retested. It's just, they feel great and they say, hey, I don't even know why I would do that. Insurance could be a pain. There's real people having problems, right? And they feel better. And so they're like, yeah, that's good enough. Because academically, what you would want is a lot of times different than, like, what you get in real life. but I think it's less, or at least my understanding of there's less science on that than you would hope. So I think what you're saying is my take on the most recent time I looked at them.
Interesting. Well, maybe I can give you a bunch of sleep studies and we can start testing people.
Yeah.
All
I
right.
mean, it would be neat. I mean, it's kind of a lot of work and everything, but giving some people some time to settle in afterwards, I think is important, So I know you had a bumpy go initially, but you kind of settled in a pretty good spot, and I think all in all healed really well. But that's not always the case, and so get you back to living normal life and back to work and eating and whatnot before you retest is good.
Yeah. I know we don't have the objective sleep study data, but you've done so many cases on sleep disorder breathing patients. Do you feel like there's some point in the recovery timeline where most benefits precipitate, if at all? Or should it be immediate for most people? I interviewed one guy who got cured, by the way, by walling.
Uh-huh.
He didn't experience sleep improvements for 3 months, apparently. And then there's other people who say, I woke up the next day, I've had perfect sleep ever since. And I'm so everyone's so confused. And this is honestly one of the hardest parts about going through this process is managing these expectations. Going, okay, I'm not cured. What's the next surgery to, okay, maybe I'm being a little bit neurotic and I should give it some time because people say it's up and down.
Yeah, I mean, I had learned early on. I think I don't know if I told you, I did a couple of fellowship interviews back when I was interested as in doing this as a resident. Um, and the one I ended up going to was in North Carolina, but the other one I went to was in Stanford. And Stanford was at the sleep clinic at the time. That was kind of the place where you did that. And I spoke to the surgeons there because you hang out with them for a couple of days and you kind of like find out about things. And they give you some nuggets that are, useful when you talk to people who have been through surgery or put a lot of people through surgery. And the info that I'd heard then, it certainly is true throughout my career, which is there's that don't get too excited or too depressed on, how they're doing right after surgery in terms of breathing, because you don't really know until they settle back in. And I think, like in my mind, that can be caused from a lot of different reasons, because quite a bit of congestion or swelling in the nose, like blood clots in the nose, that sort of thing, where you're just sitting there breathing with your mouth open. Um, I think influences people differently, right? And I think the nasal breathing, like being able to breathe through your nose at rest and where your tongue sits, is important, like airway dilator. Um, there's the resumption of nasal breathing, and then the decrease in soft tissue thickness that comes along with less vibration, right? So like once the snoring goes away, or when the snoring goes away, or lessens even, then that chronic irritation of the soft tissues starts shrinking back a bit. And I can believe that people like settle into a position where they're sleeping well, right? Like once they kind of like relearning new positions of sleep, new like sleeps hygiene type things to where they're kind of like discovering their normal rhythm again. Um, and so, I mean, I bet you there's a lot of that. I think that's putting aside the idea of complex sleep apnea and how people can get some centrals emerge right after obstructions and or the resolution of the obstructions. And so um, I think it's just messy, and it's hard for it not to be messy. So I wish I could tell you something other than that. It is true though to not be discouraged or not get too excited, like right off the bat. I mean, um, which is easier said than done. I've been a patient too, so I understand. I've been a patient through jaw surgery, but I've been through a patient of other things. And it's hard to know when you're in the spot, like if you're in a bad spot or if you're in a good spot. It's you want to do the right thing. It's just when it's a bit of a moving target, it can make the recovery difficult.
It's true. Yeah. I was looking at literature and apparently they've done studies and scans on how much edema people have over the course of a year post orthognathic.
Okay.
And I think a month later, a lot of people still had like 40 to 50% swelling. Does that sound normal? Like internally, I suppose. And then I would,
You're in externally or internally, you think? Like, you mean in the parapharyngeal walls, or do you think in the facial swelling?
I think they might have sent external. I should have read this a little bit more closely before bringing this up, I guess, to you. But
No, no. I mean, because I mean, in a month, I could maybe believe that. You said a month to a year, like how much
sorry,
swelling gets away.
they did scans like a month later, 3 months, 6 year, and at a month there was still about I think it was only 35 subjects, but like 40% of the edema was still there, and then even a year later, it was like there was still 10 to 5% left for some people.
Yeah, I mean, I could believe that on the facial swelling part. I mean, because I definitely meet people like years after the fact, and I'm always, there's the aging component. But I mean, if it's like, let's say, a year or two, I still think there's a little bit of settling on the face. So I could believe that on the face part. I mean, it obviously has to do with how much swelling you have right after surgery, um, because there are people that really swell a lot. So, um, but from an airway swelling standpoint, I just have a hard time believing that there's that much swelling from that aspect, other than um, the soft tissue thickness that just exists from all the snoring that existed otherwise. I mean, I can believe in the nose and maybe like in the soft palate there can be a little thickening that takes some time, but there doesn't tend to be that much swelling medial to the mandible, which seems strange, but I don't think there's much there. So if that paper showed it in that location, it'd be interesting. Let's see. This is you 1 week after surgery. This version of you. Your old version, the one before surgery is coming up. Did you want to see superimposition data? You want to just like start
Yeah,
looking at this and go from there, or what were you hoping on?
yeah, maybe. So it looks like he did do those little screws. You were saying those were maybes, right? And then those ones behind the molars there. That's just to help stabilize the mandibular.
Yeah, it
Um,
has to do with fixation. So the mandible, as it advances, there's this plate that holds it in place. These little screws are monocortical, so they only go through the outer cortex of bone so as not to injure the nerve. The nice things with these is they tend to give the nerve a little bit more space. I don't know, that makes a ton of sense, but there's groups of surgeons, they fall into putting these screws in. These are positional screws, they're called, or plate fixation, which is what this is. And a lot of times people are like, oh, I only do plates or I only do screws. The combination actually is sneaky nice because the plate holds it reasonably well. Because of the inaccuracy of the plate, it tends to give you a little bit more room for the nerve. And then this extra screw splits the point of fixation. So the point's here and then down here. So it's a more stable construct, while you're still getting the benefit for the nerve. So I tend to like it on bigger advancements. It has to do with how much bone overlap and that sort of thing. But the extra screws in there for that reason. So the screw, is positioned to secure the proximal distal segments, or the segment with the jaw joint to the segment with the teeth and the nerve and everything. And so you can kind of see how both of those are in there. It's kind of, anyway, with time, I've liked this strategy with MMAs or with bigger advancements. Also, just in case there's something that goes on, if people need their hardware out, they tend to need this plate out because of infection or they feel it or something. And if that's an early thing, we can delay removal because of the concern about bone healing. And so having this top screw in also helps you out with that scenario. I know you didn't have that problem, but
right. And all those, oh,
go ahead. Sorry.
well, was there anything that stuck out about my case, or was it pretty vanilla for you?
I mean, you had there's some sayings during surgery which are somewhat informal. But your bone stock was hardy. As I say in surgery, you put the man in mandible. I know that sounds strange, but it was just kind of like this. You had a lot of good bone, is all. So I think it stood out that your just bone quality was really solid. So
Yeah,
uh,
Copleston said it was dense or something. I don't know if that's saying the same thing.
yeah, exactly. Yeah, because I mean, there's different amounts of bone, but then there's also different substance of bone. Like I know that feel like to to feel how much play there is in it and how easily it is to advance and expand and those sort of things. There's a lot of variability in upper jaw expansion, and one of those I think has to do with just how thick people's bones are. So, because thicker bone just doesn't really lend itself to easy movement. So I had to do some work with that.
So I made your job harder, basically.
Yeah, but I mean, it's within the range of normal. Like it wasn't, because the revision surgery, there's a lot of scarring and stuff, and that tends to be a lot harder. So,
Is
sorry,
this
I'm
just
pulling
like
up your.
is this just like a genetic hand, or is it because my brother hit me in the face so many times, or a bit of both, or
Oh, like why is there
yeah.
more? Uh, I could. Um, I don't think it's trauma related. I think that's more genetics. It could be diet related. I think those are probably the two most likely ones. Yeah, but you've come from strong bone stock. It's interesting doing surgery over time with people just like experiencing that. Like it is different.
I think I heard through the grapevine too that my maxilla wasn't fully filled in. Was that like a something you had to do there? Or?
Well, I didn't leave the splint in, so maybe it was the opposite of that. That it was filled in, and maybe they were communicating wrong. So I had a splint ready to go in terms of the upper jaw because like the preoperative maxillary expansion scan, like this one. These images, I can change the numbers, change the colors if you want, if that's better. But they're based off of just the settings in terms of seeing how much bone is there. But where your upper jaw expanded, there was a little bit of a question of how much bone was going to be there during surgery. And so I had it as a backup in case there was still some mobility there. But it seemed to be fine. So felt like the bone was fine.
And what about movements?
These are always some minor inaccuracies to them, but in general, they're correct. So while I'm pulling that up, can I answer other things about it? I thought, by the way, that the movements were pretty dang close. So
Yeah, that's what I recall too. I think we talked about it for a moment at post-op 1 week. But yeah, it sounded like you
yeah, when I showed you like these images of it, these guys,
oh yeah. Oh,
like these, right?
okay.
Because these would have been the ones that we went over at the 1 week. I'm bringing up this 3D data set so we can just look at it.
What are like the main measured outcomes here, the main movements? If you were talking to another surgeon, what would you say you did to me?
Well, so just MMA, one piece upper, one piece lower. The amount of movements, I think Pagonion, and I could pull up your plan in terms of the plan movements. On this thing, it has you about 17, 18 millimeters at the chin, about 11 at your incisor, maybe 11 and a half. Because that has to do a little bit with the vertical movement of things. And so from the planned amounts, yeah, it's pretty close. Maybe, yeah, they're both within a millimeter of the plan. So, I would just say it was honestly, if I was talking to another surgeon, it would be just a MMA be doing. And so the amount of movement nowadays, I try to drift things forward as much as I can. So a lot of times it's just based off of aesthetics, but sometimes it's based off of absolute how far things will move. So I think looking back on it, we had a pretty good compromise on those two things.
Yeah, would you say those movements are middle of the range, above average, kind of aggressive, below average?
I would say that's probably one of the big variances when it comes to these surgeries these days is kind of how much people get with movement. I would say you're probably in the above average, but not like world record type of movement, right? So I would say I still think about it the most typical MMA. Here, let me show you what I'm looking at. I'm working on the 3D thing here. Most typical MMAs that I see, or at least I hear about, are somewhere around about a centimeter or so. in most people, at least on the surgery side, are talking about the central incisors, but sometimes they talk about pogonion moving a centimeter. And so standardizing that language would be great, by the way. So here you are.
We'll start with this video. This will be a baseline for people.
Yeah, that'd be great. This is, you see the 3D version of you. So we can kind of play with this whatever way you kind of want to look at it. But you can see the whites after surgery, blues before surgery. And so you can kind of see how in my world, asymmetry looks good. The planned result and the final result sometimes can be a little bit different. Things like your hyoid position have changed a little bit. You can kind of see where that is. Again, that's variable based off of other factors. What is true on these is your head position changes. That tends to make the airway visualizations hard to standardize, by the way, because you have a chin up position pre-op and it's more upright post-op. And so the airway changes that you see are actually biased to be worse than it would otherwise be.
So the one with the colors and stuff you're saying are probably even better?
Yeah. Because head position tends to be different afterwards. And are you feeling better on your neck, by the way?
In what way?
Like, did you feel tight at all? Like when you extend your head up after surgery?
Yeah, for sure. Yeah.
It just pulls on your neck.
Yeah.
That loosens up with some time because you tend to, on these superimpositions, sorry, I clicked forward too quick. But the spine typically isn't superimposed all that well. And that tends to be because of head position changes with these surgeries. It sounds strange, but head position influences how the airway looks on imaging. So the superimposition is based off the midface because midface, you kind of use it as a stable landmark. And you can see the blue and the white kind of becomes a hybrid color in the midface. So it's pretty good superimposition. And so everything beneath it are the things we changed. So if we kind of scroll through this, this is kind of from a side view. You can see the tubercles, the attachments of the tongue on the back part of the chin. Where they sit right after surgery is in front of where your chin sat before surgery. So it's kind of a weird thing to look at. And you can kind of see that with your teeth and whatnot. The magnitude of movement's always a little bit hard to quantify, but you can kind of see how you kind of like skip a tooth forward. You know what I mean?
Yeah.
So anyway, I think it's always neat to see these sort of things. In my world, I started doing this, the superimposition data, just to check quality stuff, because a lot of the old paper is not that old, actually. It was all kind of pre-3D surgical planning and 3D evaluation of results, by the way. And so, the discussion of how the final result actually matched the plan used to be just like panos and occlusal data and cephs. And now 3D assessment of these things is good because there's different things that come up. For you, though, it looks good.
What about if I do have, let's say, residual sleep disorder breathing, which I think is a question mark or an open question right now? Does anything stick out in my scan, or like what would I do as a patient to figure out, would I do a DICE? Would I do another CBCT, endoscope?
Yeah. It depends on where it's at. So in the absence of any other symptoms with the nose, let's say, right? Because nose right after surgery is full. This is you right after surgery. You can see how the sinuses are just full of clot. And I swear the last time I see your sinus at the end of surgery, everything is completely clean. And the same thing with the nose, like the nasal airway at a 1 week postoperative scan or 1 day postoperative scan is a lot different than afterwards. And so if there aren't other symptoms associated with the nose, then probably cone beam's a fine way to go. But DICE is likely the next best bet. Because DICE, we're really kind of looking at collapse patterns, seeing if there's soft tissue things that are hanging out back there. Because I can be convinced that there's nasal mucosa that is getting in the way. I could be convinced that turbinate somewhere along the path is starting to get crowded out. how the soft palate responds. A lot of times the soft palate's long after long periods of sleep apnea. And so reducing the length of the soft palate, those sort of things are good to diagnose on DICE. And, I would go, I think those are probably the right next step.
I just watched your interview with Reza on symphysial distraction.
Oh, yeah. What'd you think about that?
I thought it was really interesting and it makes sense to me. If someone does an MMA, are they still able to do those things, or is it kind of over for them?
Oh,
I
no. I
mean,
mean,
widening of maxilla and mandible.
yeah, widening arches. No, that's fine to do that. It just tends to be a lot of orthodontics. So just because you've had an MMA in the past doesn't take away the ability to do midline distraction. Midline distraction in terms of mandible, it's still like an open question about how much that plays a role. It's even more of an open question than it is in maxillary expansion. But
So we need more volunteers.
yeah, exactly. Yeah, and I mean, also the hard part of this stuff is trying to do the right amount of surgery, right? Like you don't want to do too much or you don't want to do too little. Getting people through multiple stages and the time off from life and the rest of the things. Um, there are certain situations where people have really narrow arches that widening the arches makes a ton of sense. But sometimes for practical reasons, they need to get airway space first. Like you just need the advancement first. And so timing and talking with providers about the different sequencing is a good way to go.
Yeah, because I looked at my scans, and what you're now saying may be marginally not in favor for the size, and my airway is 350 to 400 everywhere. It's blue and white. And I wonder if there is residual sleep disorder breathing, which again, I don't even know if there is. Yeah, that one.
You're talking about this guy.
Yeah.
Yeah,
I'm wondering how could things even be collapsing if that is the case. But I guess a dice makes the most sense, hey?
uh yeah, I mean, because again, this is right afterwards. I would expect this to be a little bit better now, but it's because like your tongue position is still sitting a little bit low on this image. This is just you sitting in the machine. Um, you still have some black space in your mouth. In theory, if we could catch that into your throat, that would be great. So if we can get your tongue up there, that'd be good. Um, but I see big airways. It's like one of the reasons why imaging, this is before surgery, why imaging doesn't tell everything, right? Like imaging's part of the picture, but it's not the entirety of the picture. Um, and so I think if there's nasal stuff going on, cone beam imaging can be good. So yeah, I just think DICE is a good resource for that stuff.
Yeah.
Yeah.
When do you think is an appropriate time for me? And again, I want to really preface this with I'm really happy with the results that we did, and I think you've been great, and this has been not that bad. Honestly, I'm really happy I went through it. 3 weeks of some discomfort for forever improved airway is worth it, in my opinion. And I feel like I got lucky too. Some people get complications and there's asymmetries and there's numbness, and it's been really a nothing burger for me, at least.
Yeah, that's great.
So
Yeah, no, I mean, I think you've healed really well. So that's it's great work on your part. So but yeah, I mean, you're right. It's a big surgery, it's a big process. And so making sure kind of understand all of it. There are things you can do to help minimize the risks of trouble and the access to these surgeries can sometimes be a bit of a hurdle too. Because like people doing a good volume of these things and kind of like looking out for all this stuff is a bit hard to find. So
it's
can be
true.
hard.
Yeah, I totally agree. I try to pump the people up in the Discord forums and stuff and say, hey, at least you got a chance to go to one of these people who've done 1,500 surgeries on sleep apnea patients, because the vast majority of the world, their currency's purchasing power is not going to get them to someone who, let's say, is more of a sure thing than rolling the dice.
Yeah, I mean it's pretty dang different. Like on the extremes, like your first 100 or maybe a couple hundred, it really becomes a different operation later in your career. Like it really is different. The stuff you look out for, the stuff that I think people are looking out for now, things like, healing trouble and numbness and just kind of ease of the process where early on you're just pretty much happy you made it through. So I know that sounds maybe a little informal, but it is the truth that a surgeon is just a bunch of humans trying to help people out, and there's enough variation and humanity to make practice um, very interesting for a long period of time. So,
Can I ask you how many surgeries you've done for people's sleep apnea or orthodontic surgery?
yeah. So for jaw surgery, I think my best estimate on patients who I've put through orthodontic surgery is right about 1900 patients. I think that's about right. And sleep apnea or sleep being part of that is hard estimate on my side. Because there's people come in like you that are just having jaw surgery to breathe better. Um, but many people are doing it for multiple reasons, right? Like they're doing it to help out the way their teeth fit and to make them breathe better. So someone who's maybe using an oral appliance for a long period of time, they develop an underbite. They come in because they want their teeth to fit, but also their jaws to move forward. Or people who have joint issues like an open bite, and we're also advancing them for that reason. So I generally estimate about half of those are for sleep, and I think that's probably right, but it might be a little bit more than that. And so from a focus on sleep, my practice nowadays, I see more sleep people than I see for like aesthetics. Um, or, I mean, honestly, it's pretty close for occlusion. But most people, there's breathing benefits of these surgeries. It's funny because MMA is like, it comes from a time where they were doing jaw surgery to fix the way the teeth fit, and then they realized it actually makes an impact on things like breathing. And so then they started applying it to a whole different group of patients that didn't even need to have their teeth changed, but just to get them to breathe better. And that's where the idea of MMA came from. And it sounds silly, but like, my professional career, we started kind of being on the lookout for airway changes, but all the other things we do in terms of the bite aspect. The idea of changing people's like growth modifications to encourage breathing is a relatively new idea. You know much about that?
No, not really. Well, it
Like
depends.
the
What do you
idea
mean
of
by that?
upper jaw expansion, like in adolescence, to help out with nasal breathing and help
Oh,
out
right.
with sleep apnea, like pediatric sleep apnea. Um, that seems a bit of an obvious thing now, but it wasn't an obvious thing that long ago. And I mean, sleep medicine as a field is young, and so I generally think that the majority of people with skeletal discrepancies have some degree of sleep disorder breathing or have some amount of consideration for that. So a long-winded answer. I don't know. I ballpark maybe around 1,000 or something. So
Are there specific sites of obstruction in the airway that are more problematic or difficult to treat? One thing I've thought a lot about, just to add a tiny bit more context, is sometimes I feel like this is just neuroticism, so don't take this, as too much, but that my hyoid bone, for example, might be displaced due to trauma when I was younger. My brother, whatever, we wrestling and him choking me too hard and maybe like pushing that back. And it's the one bone that's not attached to other bones. So it's, um, I don't know. Am I
yeah,
the,
well, I mean, I would like one of those things though. It's um I think things like muscle tone and other things can influence it. Like I could believe other aspects can influence that. There's a whole thing about hyoid suspensions for a period of time. I feel like those have kind of lost in favor as a primary procedure. It doesn't seem to be super helpful, but I mean, as part of a multi level soft tissue intervention, I think there can be some utility in it. It's just super hard to know, right? Because I mean, we're just now starting to kind of appreciate how the craniofacial skeleton influences daytime breathing. I mean, I had learned that and it is true that the narrow point in the upper airway is at the vocal cords, and everyone else is basically the same. And then I would go on an anesthesia rotation and be told that it's hard to intubate people who don't have a chin. I'm like, yeah, it is. That's really different. It's hard. Like the cervical mental distance, if it's shorter, it's a marker of difficult intubation. And
oh, sorry, what was that?
uh, like the distance from the chin to the neck, like this distance, if it's shorter, some people don't have chins. Um, there's ways anesthesiologists, so the people who manage the airway while people are having surgery, and they commonly manage it with endotracheal tubes. And they put a breathing tube in. They do that by putting a little camera in the back of the throat and putting an endotracheal tube in. It's a process of intubation, and there's ways that in the anesthesia literature for that are well established on who are difficult intubating. And it's things that are a bit obvious, like small chins. But then in small chin surgery world, we aren't really thinking about airway until relatively recent. I know that sounds strange. And then, like relating anesthesia, being like, hey, look, this person really should know that there's a surgery to push your tongue away from your throat to make all this a lot safer for you. Like I actually, I don't want to say never, but I don't even think I can remember a patient that's come from anesthesia for that reason. And it's just like, it's still of a connection, right? Like the connection of like the functional aspect of the chin and the airway part's an important thing. So I think this is I don't know, it's a good thing to get word out and have people talk about it.
I recall you saying to me that if there is still residual sleep disorder breathing post-orthognathic, it's typically nose or base of the tongue.
Yeah.
What are your thoughts about base of the tongue efforts or treatments? Do you think that like resecting the tongue is a bad idea, that people should?
Yeah. I mean, because I defer to my ear, nose, and throat colleagues. There was a time I used to do those sort of things, like I used to do dices and stuff. But now it's like, what am I going to do with this info? I kind of want it in the hands of people who are doing soft tissue surgery. And I've just generally partnered with them just because it's better to kind of have people who focus on those aspects, right? And that allows me to focus a bit more on jaw surgery. And so base of tongue, I mean, things like lingual tonsils, like, do those go away after surgery, or are there other ways to make those shrink down? Or is it really a tonsillectomy, a lingual tonsillectomy, the right approach? Base of tongue, radio frequency procedures, like epiglottis procedures, just oddball stuff and back there. Sometimes there's polyps, those sort. I defer to my ENT colleagues for that. And so I'm of the opinion with some residual apnea, it's worth the dice. Like I think that's worthwhile. Because I think I'm like everyone. It'd be great if everything went away with just the surgery, right? Like if you just, it's not just it's a big surgery, but getting you through it safely is doable. It's just at the same time, it also makes sense that there's a couple reasons to have sleep apnea, right? Like maybe there's people where it's just one thing, but it also makes sense there could be 3 or 4 things in some people. And so, you relieve the skeletal thing, the skeletal aspect, maybe soft palate being a little bit long or some redundant tissue at the base of the tongue. I think giving yourself a little bit of time though to recover afterwards before you go through another operation is good.
Yeah, no, I don't mean to re-ask this, but what would you say is on average an appropriate time to go, okay, maybe the results are in 6 months, a year, before you consider like doing a lingual tonsillectomy or getting a dice to check?
So I usually point people in the direction of a dice at about 6 months. So not that I don't want to have them go earlier than that if they're having trouble with sleep. It's just that I kind of want things to settle down a little bit.
Yeah, it
So,
makes sense.
I mean, I think most people it's around that time.
That makes sense. Okay. I'll probably do that next if something's going on, but I honestly, it is all over the place. I don't know how else to put it. Even the objective data is, and I think it has a lot to do with the sleep position. But like I said too, just over the last couple 5 days, when I started chewing, it feels like it opened up again more. I don't know.
Yeah, I mean, I think there's enough mystery here that I think you're doing the right thing by just giving it a little bit of time. I kind of find optimism in the fact that you feel better, because if it was just going bad, then you wouldn't be feeling better, right? Like it would just be consistently in the opposite direction. So there must be something trying to fight its way. And I mean, all your imaging points towards there being a good impact in terms of breathing. And it's a little bit subjective, but there's times where I feel like I could advance things a little bit further. And I don't think you're in that camp. So it felt like I was really pulling out your airway.
Yeah, that makes sense. Yeah. I would say it's been overwhelmingly positive, like maybe 85% good nights and then 15%. And almost all those bad nights are in Mexico. So
Yeah. Well, there you go. You just got to get back to Canada. All
I
right.
guess what can I ask one last tiny little question?
Yeah,
And
sure.
again, I'm so sorry. I know you guys hear this all the time, and I felt like I was so abrasive to Andrea because I was just neurotic about it. I don't understand how much stress the recovering jaw can endure. Like I would think like laying on my side of my face, let's say 3 weeks post-op is a bad idea. Or sometimes I would bite accidentally and I'd be like, oh my God, did I move the bones? Will someone know if they've moved it? Like, is it
Not really. I mean, because what you're trying to find out are things that are unknown, right? Like, jaw surgery's been going on for a long time, and they used to just wire teeth together, which wiring teeth together, keeping your teeth banded tight seems like it would be secure, but it allows mobility in the maxilla because when your jaw's trying to open or moving, grinding, then the upper can move. And so keeping things away from your teeth, then it's like, well, let's try to control the eating business, right? Because I mean, you know what it's like not chewing. You're still going to accidentally chew a little bit. I mean, not purposefully, but if you're advancing to more soft food, sometimes a little bit of chew, and it's like, well, what is a chew, and what's a bite? There's a ton of gray area here. I think for most people, it's stability. The outliers tend to be like the ones in terms of healing trouble. It's generally poor bone. It's also just kind of a disregard of instructions because there are truly people that just feel like they can get back into normal living. And I'm not sure why that is, but that is the thing. And I think being cautious is the right approach. But you don't have to be so cautious as to not live life because you can't control things like sneezes or like a hiccup, or you fall asleep and your head's on the side, or your dog jumps on you, or like your kid headbutts you. You can hope those things don't happen, but I mean you can kind of tell because there's a big change. So unfortunately the face is just like right in center, right? Like your chin's right there. And so it can and you got to use your face a lot. So just try your best to kind of minimize mobility and recovery. But I mean, I think you managed it well. So good work.
does that happen once in a while? People get hit and it moves.
Yeah. Oh yeah. Yeah. I mean, all sorts of stories. Um, yeah. I mean, because life just goes on. I've had people where they have relatively small amount of trauma and it changes. Whether the bone breaks or the fixation gives up or the bones shift in relation to each other. Then I've seen people go through quite impressive amount of trauma and it's fine. And so um, it's hard to have a unifying statement with that, other than each person is different, each one's situation is different. The surgeries seem like they should be the same, but because everyone's so different, they are like that. And so kind of general guidelines on instructions after surgery seem to be better than wait on the individual to get really specific. So yeah, you're good quality bone, and kind of being in healthcare and those sort of things kind of give me comfort that you're going to do well.